Ma'am, kindly start the presentation. Thank you. Hello? Ma'am, please start.
Ma'am, I'm just starting in a minute. Good evening, everyone. I'll be presenting the long case for today. So, this is a 1-year-old boy, first by birth order, born out of third-degree consanguineous marriage, resident of Govandi and hailing from UP, brought by an informant being mother, with complaints of inability to sit or stand since the past 3 months. As per mother, till 9 months of age, child had achieved sitting without support and was able to stand with support. At this age, mother noticed that initially, child had difficulty in holding his neck and the midline and had wobbling, followed by complete head lag over the next 4 to 5 days. At this point, child was unable to get up from bed independently, but when made to sit, could maintain his posture. In the span of next 1 month, the child started swaying to one side when made to sit and was unable to crawl or creep. In the next 15 to 20 days, it further progressed and child would buckle his knees when made to stand in the walker. The child also has history of not being able to reach for objects and unable to hold things with his hands since the last 1 month. The child has history of having inability to babble and only now responds to gestures, history of increased irritability, and history of intermittent abnormal hand movements in form of tightening and twisting of limbs during sleep noticed since the past 15 days. There is no history of seizures or any focal deficits. There's history of intermittent regurgitation of feet. There's no history of vision loss. There's no history suggestive of any other cranial nerve abnormality. There's no history of increased stiffness of the body. No history of any abnormal eye movement. No history of fever or rash. No history of episodic vomiting or lethargy. No history of recent vaccination or travel. And no history of abnormal increase in the head size noticed by the mother. Previously, child was admitted for acute gastroenteritis 1 month back for 2 days and received some IV medication. ANC was uneventful. It was a registered pregnancy and mother had taken all supplements. There are no history of abortions in the mother and she had no other comorbidity. Birth, the child was delivered full term, LSCS delivery in view of bleeding and leaking PV. The child cried immediately after birth with a birth weight of 2.75 kgs. There was no history of any NICU stay and the child was discharged on day of life 3. The child is immunized till 9 months of age. Child was exclusively breastfed till 7 months and started on top milk thereafter with improper dilution. There are no similar complaints in the family. Developmentally, in gross motor domain, the child had achieved neck holding at 4 months, rollover at 5 to 6 months, sits without support at 9 months, and stands with support at 10 months. With arrow. Currently, the child only has partial head control. Fine motor, child had reached bidextrous reach at 4 months, could transfer objects at 6 to 7 months, unidextrous approach at 9 months, and immature pencil grasp at 9 months. Currently, the child keeps his hands and fists closed. Language-wise, till 8 months of age, the child could speak in bisyllables and responded to his name. Now the child can't babble. Socially, the child had social smile at 2 months. He could wave bye-bye at 9 months. Now only smiles at the mother. Summary.
So, what is your analysis of the onset of the complaints? So, we have to first try and define the anatomy of the problem and then go further. So, what is your analysis of the first complaint that the child had difficulty in holding neck in midline and had wobbling followed by complete head lag over next 4 or 5 days? So, how will you analyze this?
In this child who had previously attained his milestones adequately as per his age, now the onset, because it over the course of 2 to 3 months, the child.
No, I am saying don't take the whole picture. Imagine that this child came to you that time on that 5 days. So far, the only complaint is that in the last 5 days, this has happened. He's not able to keep his head in the midline. So, in other words, he has lost head control. Correct? So, a 9-month-old who was developmentally normal till now has lost head control, is the complaint at that point, right? What would be your thoughts?
If it was just a normal child who has come with only with complaints of head loss of head control,
Yeah,
firstly,
only that second paragraph of yours.
one thing would be to look for any local cause.
Like,
If there was nothing, as in if there's a mass or something because of which the child is not able to maintain his posture, because of which there is falling of head.
mass where?
Yes, with the neck,
So,
you say.
so see, we're just learning how to think. So first we have to decide the anatomy. So by anatomy, what do I mean? Ki why have I lost my head control? So are these muscles weak, or has the head suddenly become very big or suddenly become very heavy, or what? And then if they have become weak, then the cause is at the spinal cord, at the brain, or something metabolic, or what, something like that.
So in this child, like we had asked about history of any increase in the head size to rule out that agar gravity ki wajah se if it was falling. So there was no increase in head size. And for the muscle part also, the child was able to maintain the rest of his posture at that point, and he had power in all other muscle group. So it didn't seem very likely that he had lost power as such in the muscle. That seemed like it felt like that he was going into regression, because he was like, for the milestones that he had achieved earlier at 9 months, now there was a loss of that milestone.
Okay. In your next sentence, you have said child was unable to get up from the bed independently. So and just now you said power looked normal. So these two things don't go hand in hand.
Like, after the neck control wala complaint, like after the 4 or 5 days of neck control, then gradually then he was not unable to get up from bed in the next 10-15 days day frame. And during that time, he could sit when made to sit. Like he could maintain his posture, but was unable to get up from bed. But that was like 10-15 days delay.
I think he has already told you that he cannot hold the neck, so there is something wrong with these muscles. The question is, what is wrong? Motor system? If motor system, tone, power, or both? So that's what we start looking at. At that stage, you would not know what it is after the first para, because all that we know is hypotonia, probably with loss of power or without loss of power. We don't know that. But a sudden episode of hypotonia is likely to be with loss of power. So at that stage, we know that there is a loss of power which looks like hypotonic. Now, hypotonic at that stage doesn't mean it's not apomotor neuron. It could be both, right? But thereafter, we want to know what has happened to the rest of the muscles in the body. And therefore, you get on to further to say that there is that difficulty in holding the neck, and thereafter, unable to get up from bed independently. But when made to sit, he was able to sit. So again, there is some more muscle weakness coming up in this child. Okay. So it's an extensive area involved, that much we know. And thereafter, you have said that he is able to maintain posture. So apparently, when made to sit, he would be able to sit. But thereafter, you have said that started swaying on one side. So again, the question is, what is that swaying that has come up? Is it some incoordination? Is it some abnormal movements? So is it a cerebellar involvement? So we start looking at all that, right? And thereafter, it's progressed and child would buckle his knees and he is when made to stand and walk. So now what do you make out of this progression? We started saying that there is a loss of power. Now we have said there is an extension of loss of power. Now, where do we put your anatomy like this now?
So you are not convinced that there is loss of power. You want to say something else?
No.
Trying to define the swaying that, as per mother, he was not able to maintain his posture. I've written swaying in the sense that he would fall when made to sit.
Fine. So the swaying tells you that there may be still posture abnormality, maintaining not posture, but still there may not be a weakness. So then what is it? When it started with not holding the neck and head, was it with normal power?
So just a small correction. So see, when you write that started swaying to one side when made to sit. So now we need to take this history properly. So if when made to sit, always swaying to one side would mean a cerebellar problem. And swaying would mean kind of going a little this side, but without losing posture. And if you want to convey that he could no longer hold his posture, then don't use the word swaying. And that fall or means lack of maintaining posture and falling could be on any side. So that is not cerebellum. Then that is further truncal weakness, right?
That was my error. But he would fall on both sides. It was not a particular
right.
side. And he was basically not able to maintain the posture. He would fall when he was made to sit. So it was like a truncal weakness, not fair.
So now just thought process that weakness, it seems started from the neck muscles and then has involved the other areas and even the trunk now, and now not able to crawl or creep, so legs also probably. So where do you think is the problem, central or spinal cord?
Suppose had it been the other way around, starting from below and going up, where would be the lesion? Spinal cord? Then what is this now?
You said central, think and tell and answer reasons for or against. Sit. Just because the order is from top down doesn't mean it is central. We need to have some reasons to call it central or peripheral.
I feel it is spinal cord or like peripheral, because there is like, I feel there is no inability to do movement. Child is trying to do movement. Like whenever he's made to, whenever he's put into walker, he is trying to stand, but he is not able to, and that's why there is buckling of knees. So I feel there is like, in a layman terms, there is no problem in the command given centrally. There is issue with ability to maintain that command or that power. That's why I feel it is spinal or peripheral.
So I think two, three things at this point we want to know. One is, if it is coming from above and going below, what has happened to muscles in between? Has the respiratory muscles involved?
There was no complaint of any
So
distress.
it is
by the-
jumping from one area to another, right? Had it been a GBS going up like this, it would have followed an order and sequence. This has not followed that. Have there been a cranial nerve involvement?
Said something about swallowing or some defect.
Intermittently in the past 15 days, the mother is saying that the child is having regurgitations.
So there are some other muscles also involved, but what we have understood is it's not in the same sequence.
That regurgitation, it could also be due to inability to maintain the posture.
So we said that at that time. See, the point that we want to make is that this is not in order, it's jumping. What does it mean? There are multiple areas involved anatomically. So we have to find the etiology where multiple areas. Now we come to next issue. Is it an upper motor neuron or a lower motor neuron?
What do you all think? Just generally, even take little bit data.
muscles.
Or is it?
Means
the
then
lower
we'll, sir,
motor
first
neuron?
upper or
In
lower
lower
and then,
motor
yeah,
neuron, we go further.
in lower we go further.
So had it been an upper motor neuron lesion, you would have something higher up or right up to midbrain here. Here it's only a lower cranial nerve something. So possibly it's a lower motor neuron, but could it be still an upper motor neuron? That's what
Battery of the laptop. Yeah. What are your thoughts on lower motor neuron versus upper motor neuron? How do you decide clinically? In history, how do you decide upper motor neuron or lower motor neuron? Whatever, little thoughts that come to your mind. What are the features of upper motor neuron?
Hyper rigidity in UMN, increased tone will be there. In lower motor, hypotonia and areflexia. Uh,
If you have to get the same thing on history, what will you ask and what is there in this history? You said
pyramidal tract is involved, right? So is it cortical, subcortical, internal capsule, midbrain? Can you get all that in the history? You get the point. Imagine hemiplegia. Where would you localize? So
Hemiplegia, it will be in the corticospinal tract mostly, because there it's more compactly packed, so the weakness will be more pronounced. As it comes down, as it deviates, the fibers deviate, so the weakness will be less comparatively.
what I'm asking is what history you would ask to get whether it's a pyramidal tract, whether corticospinal, corticobulbar, whatever, but the pyramidal tracts. And what question, had it been cortical, some changes in the cortex? Okay, if it was localized, maybe frontal lobe, maybe parietal lobe, somewhere. There is nothing of that sign. Same thing down, okay, come to midbrain, there is nothing happening with third, fourth, come down, pons, medulla, but somewhere there is lower cranial nerve involvement. So the question is it still a central problem? So what is your comment on that? Some swallowing difficulty. So could it be the 9th, 10th one there? If that is so, then it's central. But if it is central, then it is not associated with any areas around that. And therefore, if it is so, then it's the nerve doing it. Okay. And therefore, like a GBS can involve the nerves, even central, but without involving the other parts of the brain. Had it been so, the medulla was involved, pons were involved, you would have other functions involved. Here, therefore, it's possible that there is nothing happening up there, but the nerves up there might have been involved. You get the point what I'm saying? So now the question is, if it's a lower motor neuron affecting even the cranial nerve, then where do we stand? Had it been a pseudobulbar, we would have had some different stories. So this is not pseudobulbar. Okay. So then the question is, what is the anatomy in the lower motor neuron? Is it nerve? Is it neuromuscular junction? Is it muscle? That's what you are saying. So what do you think this must be?
So what is the typical in the lower motor neuron? We start from anterior horn cell, right? So do you think this is a anterior horn cell? Which anterior horn cell disease do you see in pediatrics? SMA. So do you think this is SMA? Why not? Very rare name, but clinical presentation.
SMA may start any time, but generalized involvement. Okay.
So it doesn't slowly progress like this in a sequence from top to bottom or bottom to top or something, right? So that is out. Polio, for all practical purposes, we are not seeing. So SM, anti-Johansen. Then nerve root. Classic example was GBS. GBS is usually below upwards. Can you have above downwards GBS? Can you have a variety of GBS which starts from above downwards?
Yes, it does.
You can. You can. Forget the name. Names to even I don't remember. But you can. Now tell us whether this can be that above downwards GBS. In
No,
fact,
we discussed just now. No, it is jumping. Okay. It's not coming down in
understood
sequence.
why it's jumping. If it was really above downwards, involving all the nerve roots one by one, starting from cervical, thoracic, it should have involved the respiration, which it hasn't, right? So it is not that either. Can it be peripheral nerve? No. Can it be nerve root? Sorry, NM junction? The history is not like that. Can it be muscle myopathy? No. Why not?
Why would there not be any this an axial muscle involvement? And it has predominantly gone from head then to the truncal weakness, and then mostly the leg weakness is also associated with. So there is no complaint of weakness in the axial system, and also the gradual like muscular atrophy. Why should it be so gradual?
So muscle diseases are more chronic or they are very acute, like metabolic problems, hypokalemic paralysis. So this pattern over 3 months doesn't fit into that also, right? So we are now foxed. Ki if it is LMN, then we are not able to place it anywhere. Okay. And we already said that skipping and all that is something very funny. So it could well be patchy but central. So now we have to look at whether we get any signs of UMN here, right? So now you have mentioned that there is intermittent abnormal hand movements in form of tightening and twisting of limbs during sleep noticed since last 15 days. So what is the interpretation of this and what are your thoughts?
Maybe he's having an increased tone, like dystonia. This way.
So maybe it is dystonia, but what is the problem?
Like, it should be there awake also, not just in the sleep. But mother has mostly noticed it during the sleep.
Correct. So all involuntary movements are in fact almost disappeared during sleep and they are there in the awake state, right? So that's your odd point. Do you think this is raised ICP and decerebrate, decorticate posture?
Why? If there's no tightening of the lower limbs and other. She's just mentioning the fist and the tightening of a particular muscle group at this point. Yeah.
So this could still be some basal ganglia involuntary movements, but
So now
it's
we
not.
go up.
Yeah.
Now we go up.
Exactly. So this is your first clue that look, this was not LMN like you were thinking. It could be UMN probably, or at least some other area is getting involved in the form of basal ganglia.
So I think that's how we have a disseminated lesion. Now the question is, you have a basal ganglia and the muscle. Okay, we could not place the weakness at one of the neurological issues. So is it really a muscle involved with some other parts of the brain?
And then I think when you look at the some other history which you gave us, so you also gave us history of uh, regression of speech, right? So now that makes it where? Where is the lesion? Cortex. And this is regression. So that means then there is a multiple areas of the CNS getting involved. That's your first thing. And because that has also got affected, it brings us to one issue which you said earlier. Okay, all these motor functions, are they regression in ability to do it or are they loss of power? That we will have to re-examine now, right? Because when a baby has a regression of milestones, it is not necessarily loss of power. Is forgotten, or is not able to do the thing what he used to do earlier.
So I think let's come to the conclusion that you have different parts of the brain involved. Cortex, yes, maybe a frontal part or the uh, speech is involved. So it could be Broca's area or even. So we'll have to again ask whether receptive language is involved or not, or it's only the speech is involved. But we have an encephalon involvement. We have a subcortical lesion. So again, multiple sides and possibly something again intermittently getting involved. So the question is, whenever there is a muscle involved, apparently, okay, whatever the cause of that muscle involvement and the brain involvement, then the first thing that comes to our mind is a mitochondrial involvement. Okay. And classically, a mitochondria are manifestation of mitochondrial diseases are maximum in areas where there is a lot of energy involved. And their muscle and the brain comes higher up, maybe to some extent the liver. And therefore the question is this a mitochondrial regression in a normal child? So something neurometabolic, okay. And what kind of neurometabolic? So question is it a mitochondrial? There are some other defects neurometabolic which involve also the periphery and the center. But at this point of time, we know that it's a neurometabolic disorder, possibly fits in mitochondrial disorder to the best of my thinking.
Now, you said keeps hands and fists closed. So what does that suggest?
Probably due to the tightening that he's having at this point, that the mother was mentioning earlier. So maybe it's the dystonia because of which he's unable to now carry forward the thing.
These are some signs of either basal ganglia involvement or upper motor neuron, but more importantly, more looks like basal ganglia involvement, right? Okay. So now give us the summary, your summary.
Even the cognition has gone down. So it's a multiple areas involved, right?
Summary: a 1-year-old boy with normal birth and antenatal history, who had earlier achieved normal developmental milestones till 9 months of age, now having global regression of milestones with no significant past history and no history of seizures, is a case of insidious onset progressive neuroregression with motor predominance to rule out white matter neurodegenerative disorders, metabolic, genetic, and mitochondrial.
I think one of the mitochondrial illness, if I recall rightly, is a Leigh syndrome, where there is a subacute progressive encephalopathy. And that's a mitochondrial disorder, fits in age-wise. Okay. So that may be the first possibility. Well, these are all neurometabolic, really. So when you say metabolic and mitochondrial, they probably, and many of them are genetic as well. So to that extent, your second, third, fourth looks similar. Neurodegenerative probably doesn't fit in here very well.
So whenever you talk of white matter neurodegeneration, what would be your clinical signs? How will the patient present? So first let's think of a white matter neurodegenerative prototype. What do you think?
They typically Tay-Sachs. Okay. Spasticity.
Spasticity is usually there in the optic. I actually put a white matter because I thought motor involvement was more than the other.
You're right.
milestone.
You're right. We are learning. So see, white matter degeneration. Let's take it one step further. When we say white matter degeneration, it means what? What is getting degenerated? The myelin sheath of all the tracts and all the nerves and all that, right?
Yes.
So that would lead to, that would be upper motor neuron, and therefore it would lead to spasticity, right?
On examination, the child was conscious but irritable, febrile, heart, with a pulse rate of 130 per minute, normal involvement, volume and regular rhythm. Respiratory rate of 38 per minute. Saturation was maintained and perfusion was maintained.
Wait, go back. Anything odd in this?
Yes, duration in the given situation, if we are thinking respiratory muscle involvement, then the tachypnea should be there, and then one the pulse rate and RR are not concordant also.
So why is the pulse rate 130 when you are saying it's afebrile?
Actually, at that time,
It's also 38. We are just teaching you that don't do general examination mechanically. Everything you just think about why it could be. Okay. Now, Dr. Palniraman is saying you said it was a irritable child. So even irritability could explain that. But think, every time think, because these are small clues which sometimes are very valuable. Okay.
On anthropometry, his weight was 7.2 kgs, -2 to -3 standard deviation. Length was 64 centimeters, less than -3 standard deviation. Head circumference was 46 centimeters, 0 to +1 standard deviation, and weight per length was between -2 to -3 standard deviation. Impression was moderate acute magnitude.
No, but that is just your usual moderate attitude. But in relation to this child, you have to talk.
And for Dine's formula, so we had like we were seeing for the head circumference also because he's short stature, the length is less. So for that length, head circumference was more.
So if you're saying that like weight, length and the weight for length is all negative, -2 to -3 SD, then if you're considering head circumference is 0 to +1, so it can be considered macrocephaly maybe because it is relative, it is high.
Any other thoughts? So, or you want to answer what he said? So he's saying that if weight and height are so low and head is high or normal, so is the head large? So what are your thoughts on that? And please correlate it with the history. Okay, don't just look at the readings directly, only at the readings. I want you to come out with one very big point in the history. You said this child was normal till
9 months of age. Then he
so
said,
till 9 months, if this child was bang normal, then you expected his growth to be normal till 9 months?
like actually in history also like he's not feeding wise also there's a calorie deficit and also maybe his growth was also affected before this entire onset of the disease.
Okay, fine. So comment on the length of 64 centimeters. At what age do you get 64 centimeters?
5 to 6 months. 5 to 6
5 months. Okay. So you have a 1-year-old child with a length of 5 months who was normal till 9 months. So now if you are saying that his nutrition was also bad, then do you think a 9-month-old could have the length of a 5-month-old?
And weight 7 point, which is not that bad.
So the things to learn are, first of all, 64 seems to be wrong only. Okay, we need to recheck that 64. It doesn't fit in by any standards. Second, the point to remember is he's supposed to be normal till 9 months. So you have to correlate his nutritional history, get to some figures at 9 months, and then see how this illness in the last 3 months could have altered those figures to get you the present figures, right?
I think like the length we talked about, look at the weight also. Suppose it was 2.5 kilo, it could have been a little more as well. But if it was 2.5 kilo, then would a normal child become 7.2? We said 50 centimeter becomes 64 generally by 5 months. Now 2.5 kilo, when would he come to 7.2 after how many months? Then we will know the weightage and the lengthage. And if it is not much different, it is different, but not much different, then we might say it could have been partly constitutional, partly nutritional. So if you look at first 6 months, you would get at least 4 kilos. Okay. See, the answer is that 9 months. So 8 to 9 months. And the length is 5 months. So quite a disparity. Now could be constitutional partly and could be nutritional partly also. And if that is so, then the head circumference is preserved. So we know that the neurological problem did not start early, but the nutritional issue did exist, possibly also some constitutional, right?
On head to toe examination, head appeared normal in size and shape, normal eyes and ears, but there was no significant finding on head to toe examination. On systemic examination,
One sec, you said AF wide open.
sir, actually, I rechecked after this whole thing. It was open, AF is open, but then it is 2 into 2 only. Like I went back and it is not big.
But 2 into 2 is also big at this age, at 1 year, no? So what? Cause hydrocephalus, hypothyroid.
Given the short stature along with it and thinking of the
Hypothyroid, no? You're thinking of what?
the nutritional components, which I was thinking of rickets, but then it's a disease of growing bones, so not probably. I
It's a
guess.
growing bone in that age. Okay, so if you say disease of growing bone, then circumference, I'm sorry, anterior fontanelle is affected in a child who starts with rickets because it's an early onset disease and the head growth is maximum in the first few months and first year of life. So anterior fontanelle does get affected with rickets, but that may be just one of the causes.
On systemic examination, on central nervous system examination, higher mental function, the child was irritable. Cranial nerve examination was within normal limits. On motor examination, the tone was normal in all four limbs. There was intermittent dystonia, but otherwise the tone was normal. And power was more than 3/5 in all limbs, and reflexes were there was a hyper reflexive 3+ in all the this thing. All reflexes were 3+, and planters were extensor. But there was no abnormal sensation, no cerebellar signs, and no meningeal signs, and rest other systems were within normal limit.
How do you look for abnormal sensations in a 1-year-old? You can't.
For pain, but otherwise no.
It is also difficult because your child is already irritable, no? So it's difficult, right? Okay.
Summary.
So first tell me now your CNS examination, what have we found? We had discussed this in history. What have you found on examination?
There is a hyperreflexia, and
Okay.
intermittent dystonia is also there.
Dystonia actually is always intermittent, right? It's in fact, it's in the definition of dystonia. Then, what about power?
Power appears to be nominal if there's no loss of power in the limbs.
So, we had discussed this that earlier that whether there is affection of power or whether it is loss of the ability to do some movements. Okay.
Summary. 1-year-old boy, normal by birth with no past history and insidious progressive loss of developmental milestones with dystonia and dysreflexes in an immunized till date child is a case of neuroregression. Most likely, I had kept it to be leukodys.
Okay, bye.
Again, well, I was thinking in the same thought process as earlier that it looked more white matter to me because of the predominant motor. Even the milestone size, it was more gross motor and fine motor affected than others. So I thought it was more white matter involved there.
Yeah, but
And age-wise also, and then insidious and all such. So.
But you have a significant regression of speech and even of cognition. No? You said
Yeah.
social smile and all. It's now only social
Social
smile
smile.
left. So to that extent, there's a lot of gray matter involvement also, right? Okay.
I think the typical, all those three means in leukodystrophy. Okay, whether you mean metachromatic or mean Krabbe. Now, coming up early, I think typical leukodystrophy should have started with spasticity. Here, that has not been a story. That's number one. Plus, of course, there is some gray matter involvement, but that comes once the white matter goes on worsening, the gray matter is also involved. The so the onset possibly did not fit in what we said about the neck being not being able to help. The metachromatic leukodystrophy has a macrocephaly. Distal doesn't have a macrocephaly. It's just a normal head circumference. And again, MLD also has some neuropathy. So possibly it's not an
Starts lead by 1 month.
yes. And therefore little early. Krabbe's is a very severe spasticity. There is no doubt at all. Krabbe's is one of the most severe spastic leukodystrophy. So from that point of view, leukodystrophy, yes, you have an upper motor neuron lesion. So you are right that it's a white matter, but the onset does not look like a typical white matter degeneration. So to that extent, we'll have to again recheck. Sometimes the history given by the parents may not exactly be what it has actually happened. So we can understand that. So possibly when we confirm this diagnosis by neuroimaging, we will have to get back to the parents and say whether there is some difference in their reporting to you or our understanding what they've said. But I think every leukodystrophy should start with spasticity. This has not started like this. Okay, and to that extent, again, there is a basal ganglia involved. So you have not typically any of those, and you might have some other disorders like a gray matter, whether it started with a gray matter, but not with a seizure. So that was not apparent. I think these are the things. We'll have to look at what the neuroimaging has shown.
Actually, this child could not be evaluated. Like we had to be intubated in the morning. So the neuroimaging is still pending. We had just done the basic baseline workup and metabolically we had sent that definitely that came out to be normal. We were planning to do a neuroimaging, but the child wasn't. So he's currently high.
So next time you tell us what happened.
Some of the curative disorders like multiple carboxylase deficiency, for example, has, to my remembrance, also the basal ganglia involvement. So are we looking at some of those things which could be even curable with simple vitamin B, biotin, whatever?
Sir, instead of going through all those lower motor neuron muscles and which should be done as a practical training for them, if the child is losing motor milestones one after the other very fast, without much loss of power that we like typical like anterior horn cell disorder, losing milestones one after the other, and associated loss of other milestones, it has to be higher up only.
No, sir, you're right. So the
Yeah.
and
This is
see,
one of-
like you are using the word progressive loss of milestone one after another. They presented as a progressive loss of ability to
Yeah,
do
no,
this movement,
or no,
which has
progressive
there's
loss
a
of- yeah,
difference.
progressive loss of gross motor milestones, we can say, is either power or straight higher.
Correct.
There's nothing in between.
Sir, they are saying that this baby had to be intubated today morning. So all further evaluation is pending. So they'll tell us next time.
In fact, when the baby started, requiring a ventilator. Yeah.
Is it the respiratory muscles being involved that is needing a ventilation? Okay. Aspiration.
Yes, you wanted to ask. I was about to say the same thing. If there is respiratory load.
So just a thought that if a
Ripa cause for intubation, they are saying probably aspirated in the ward. So that is the cause for intubation, and USG skull was not done yet. Yeah, MRI was planned.
uh, stretching a little bit, if I see the child or we all see the child at 1 year with loss of head control itself, it is highly abnormal.
Yeah.
First
Absolutely.
complaint of loss of head
Head
control is
control.
very abnormal.
Yeah, just because apart from a very big growth of head, no muscle weakness will go. Local sprain and pain are less likely. Straight you jump to the higher centers. I do expect that there has to be associated higher center involvement also.
This tells us in our YouTube channel, I did a small video on how to make sure that the history given is exactly what we understand. And I think there are many times like this. So we have to make sure that the history is, every time we say history reliable. But if I ask you, how do you convince yourself that it is reliable? Then we say the mother is always reliable. But the mother is talking what she understands or what she feels like or she believes like this. And I think there must be some such data. But it's nice. These are the real life situations. We can't have a mother who knows everything like a medicine, okay, and then report to you. So we understand the limitations of the mother reporting and our understanding. That's where we get foxed and we have to depend on investigations, right?
Good afternoon. I'll be presenting.
Hold closer like this.
um, 17 months old male child, third by birth order, born out of third degree consanguineous marriage, residing from Basti and hailing from UP, Muslim by religion, Jubair by community, presented with complaints of increasing paleness of the body since 2 months of age. Child was apparently all right, 2 months of age, till 2 months of age when mother noticed paleness of the body with weakness and refusal to feed. For the same child was admitted in a private hospital for 3 days, where blood investigations were done, which showed low hemoglobin, for which blood transfusion was given. Child also had complaint of loose stools, 4 to 5 episodes, semi-solid in nature, small quantity, no, non-blood stain, yellowish in color, not associated with vomiting, distension of abdomen, fever, worms and skin. There is no history of high-colored urine, no history of clay-colored stools, no history of epistaxis, gum bleeding, or any other bleeding manifestation, no history of poor weight gain, no history of pica, no history of breathlessness, swelling of feet, no history of recurrent infections or bleeding from injection prick sites, no history of abdominal distension, jaundice, no history of similar illness in the family members. Past history, child required multiple blood transfusions since 2 months of age at a frequency of every 1.5 to 2 months. And the pre-transfusion hemoglobin was always 3 to 4. Post-transfusion, it goes up to 6 to 7. Then again, after every 1.5 to 2 months, it decreases. So she required multiple transfusions. The last transfusion before admission was 10 days ago from an outside hospital. ANC history. The mother is registered. IFA supplements were not taken. PT injection was not given. ANC scans were done, which were told to be normal. There was no blood transfusion in mother. No other maternal comorbidities. Birth history: full term vaginal delivery, home delivery. Baby cried immediately after birth. Birth weight was not known. No history of neonatal jaundice. No history of NICU stay. Birth vaccines were taken later at 1 month of age. Developmental history: gross motor, walks with support. Fine motor, scribbling is present. Language, bisyllables present. Social, parallel play is present. Developmentally appropriate for age. Immunization till 1.5 months. No optional vaccines or special vaccines were given. Dietary history: till 6 months of age, child was exclusively breastfed. Breastfed along with goat's milk was given. Complementary feeds was started after 6 months. Family history: the mother is 35 years old. The father is third degree consanguineous marriage share. The eldest son is 8 years old. Coming to the anthropometry.
Wait. Your history is over. Okay, go back. Go back. Yeah, the second slide. Come. So one of our online viewers asked, when were these loose motions that you have mentioned?
At 2 months of age, it started along with the increase in paleness.
Okay.
But now it has resolved.
So that was only for 4-5 days.
No, it continued till admission, but then now
No, baby is how old now?
17 months.
So 17 months, and that was at 2 months of age.
Yes, ma'am.
So last 15 months, there are loose motions.
So on and off, loose motion is there.
So we need to understand this properly. See, when you say 15 months on and off loose motions, what will we gather from that? What will we understand? In what disease or in what situation will somebody have loose motions for 15 months on and off? Malnutrition, okay.
Absorption.
Malabsorption. So then that will become your chief complaint, no? Right? The loose motions will become your chief complaint, and there'll be a lot of description to those motions and all that, right? So again, this history you need to get properly. But anyway, let's come to the main history. So at 2 months of age, mother noticed extreme paleness of the body with weakness and refusal to feed. So what are your thoughts at this stage? At 2 months of age, mother noticed paleness of the baby with weakness and refusal to feed. So what would be your thoughts? So that paleness suggests what? One minute. Hemolytic will come to. That paleness suggests what? Anemia. And weakness and refusal to feed suggests what?
Might be due to iron deficiency.
Any other thoughts?
During the same time child was sick, like he was having the loose stools and all, then was the refusal to feed also related to him being lethargic due to that acute illness?
Okay,
That could be
very
one
good.
thing.
Now suppose the refusal of feed is related to that anemia, then what does it mean?
Irritated
Because of the
We'll
dietary.
come to the cause of anemia. I want you to forget all this. If I ask you, tell me your top causes of refusal to feed. in pediatrics? Your first cause will be,
Some acute illness.
okay, acute severe illness. Then
if the irritability is due to, like, as ma'am said, nose block, like that can also be one reason. And if there are some severe infection, some CNS infection, because of which the child is irritable and having refusal to feed. And these
so you would have asked whether this baby is also breathless,
see.
as in anemia and cardiac failure will give you refusal to feed or difficulty in feeding. Now again, there's a difference between refusal to feed and difficulty in feeding. We maybe will discuss that at some other time. To understand, what is the difference?
In difficulty to feed, like child is trying to feed, but then because of excess effort, there is like the
Correct.
forehead setting and everything that will
Correct.
get along with it. And
And
refusal, it's because of irritability. The child will not take only.
Not because of irritability.
like-
Refusal is child doesn't want
Want
to
to
feed, which takes it straight to CNS in most of the cases, right? Fine. So now that would tell you that this anemia is very severe. And is it slow or fast?
Fast, because
Fast.
it causes congestion.
Right? Yeah. So now tell me, I'm just arguing that this is physiological anemia, no? 2 months is the exact time when you get physiological anemia. So what's the problem?
The child is requiring blood transfusion frequently. Yeah.
The anemia is so severe that there is refusal to feed. So that is not normal physiological.
So physiological anemia is never so severe. Mother will not notice and come with pallor as the chief complaint, and then all those other things, weakness and refusal to feed and all that, right? So this is pathological anemia. Now, what could be the different possibilities? So first look at the groups and then try to tell us which groups are possible. What are the groups of anemia? Groups as in one is
Nutritional.
very good. So nutritional, we'll call it deficiency. So one is that. Then which other group?
Hemolytic.
Hemolytic, very good. And so bone marrow problems, third group. And fourth, blood loss, hemorrhage. Now which of these here? Or which you can rule out? You can rule out blood loss. Okay. Can you really rule out blood loss? Can there be hidden blood loss? Which hidden blood loss? So is occult blood in stool so much?
So is occult blood enough to explain the blood loss? For suppose he's losing blood every day for 2 months, then he will become pale. But is that blood loss enough to cause so much of pallor? Then it is not occult blood loss. Then it has to be something which was obvious. So he's losing blood in front of us, and therefore it is. So blood loss is one. Occult in 2 months is less likely. Obvious would be more likely if it is hemoglobin has fallen so much. So blood loss and sudden blood loss, he has lost so much of blood 2 days back, he bled. And yesterday also he bled. Acute blood loss by chronic.
So maybe not refusal to feed and all, but which blood loss of a big quantity can be hidden in a 2-month-old? Very good. Subdural hematoma. Very good.
I think what we mean by that is this is a large collection, but slowly occurring. Okay. And therefore, that hidden slowly occurring at this stage is only subdural hematoma. Subdural hematoma is venous bleeding. And venous bleeding is never exponential sudden, whereas an arterial bleeds are sudden. So subarachnoid hemorrhage will come, intracerebral hemorrhage will come suddenly, but a subdural will go on and wait for another week and he would throw a focal seizure. So subdural, keep in mind, but we need to know whether this baby has a risk of developing subdural hematoma and what is the risk factor for a newborn who develops slowly and manifests at 2 months a subdural hematoma. So who gets subdural hematoma? Head injury. Which situation you get head injury during birth process?
Yeah, assisted delivery, vacuum,
So keep
forceps,
that in
or
mind.
something.
So we will just, at 2 months of age, we will look carefully whether there is any subtle symptoms. Irritability could be a raised ICT coming up, though fontanelle is open, so generally it doesn't present like this. Could it be hemolytic other than hereditary?
It can be infections like malaria for in the 2 months time when it is first discovered.
One kind of hemolysis coming up at 2 months of age is ABO incompatibility. And that may come up slowly. And then you see a child with physiological anemia on the top of it and ABO incompatibility. So severe anemia at 2 months of age could be a combination of these two, though not physiological alone. So ABO incompatibility. So it may be a good idea to ask whether the parents know about the mother's or the baby's blood groups, right?
The newborn. Late onset hemorrhagic disease of the newborn.
Yeah. So then if you look at ABO incompatibility, other enzyme deficiencies also come up, but they are more acute.
Late
So this is
onset,
slowly
usually
developed.
around 5-6 months, presence of CNS bleed, but they are severe bleeds. And those who come with early onset, you mean the vitamin K deficient, the hemorrhagic disease of the newborn. They usually have a significant gastrointestinal bleed. They'll come on day 5, day 6 with high color, bloods, obvious blood loss, black when you're those fellows who are late hemolytic will hemorrhagic will come around 5-6 months of age. The slow hemorrhage usually subdural, and they may come for failure to try, vomiting, and then maybe fontanelles bulging. So, but CNS bleeds, and the vitamin K, of course, we invariably give vitamin K. Only few days back, I saw a baby who was not given vitamin K. I asked them why not. So they were told by the obstetrician that these your babies have tendency to clot excessively. And therefore we are giving, so if you give vitamin K, then there's an increased tendency to clot excessively. I had tough time telling them your baby is 4 months. Please come to me and take vitamin K because late hemorrhagic disease thought over and then came after 15 days and fortunately did take one dose. So late hemorrhagic disease. That's a different story. So a 2-month baby coming with hemorrhage, obvious or occult. Occult maybe here or maybe Meckel's diverticulum or somewhere the baby is using constantly. But if it's acute blood loss, they will come with hemorrhage. Obvious hemorrhage and very acute means shock. Will not present like that. The baby will be in obvious shock. So also for hemolysis. Acute hemolysis is a sick baby for whatever cause. Chronic slow growing hemolysis can present the baby like that. So we saw hemolytic, we saw hemorrhage. These were 2 cases of loss of blood, so to say. Obvious loss of blood or loss of RBCs. Anything apart from that?
So in hemolytic, sir asked a question, Amdekar sir asked, can it be acquired hemolytic? So can you answer that? We're just thinking everything, then whether it fits in or not, we'll see. So which acquired hemolytic can come at 2 months of age? Very good. So what will the drug cause? Very good. So G6PD deficiency and drug-induced hemolysis. But then, as sir just said, there would be a acute presentation, there would be dark urine, sick child, and all that, right? So this doesn't look like that, but it's possible. And what about congenital hemolytic anemia? Now run it through your mind and see whether there are any problems or any thoughts that come to your mind. So which congenital hemolytic anemias can come with pallor at 2 months of age?
Alpha thalassemias, hereditary spherocytosis.
Hereditary
Like-
spherocytosis.
In infant,
Yeah, but 2 months is little too young, baby, but that is also to be good. They will also have icterus, other hemolytic anemias may not, but spherocytosis, yes.
So very good. You said alpha thalassemia, not beta.
I think one more cause at 2 months is a congenital malaria. Yeah. And that presents like a thalassemia major only.
But sir, no fever, malaria,
No
or
fever,
malaria?
no
Yeah,
fever. So
no fever.
I think these are the things. The question is, it may also be a thalassemia, but at 2 months of age, we would have gone through all this.
Another possibility to be kept in mind, difficult to confirm, is if you see a baby out of proportionally pale, maybe or 2, 3 months, maybe there has been something gone wrong with the clamping of the cord. Suppose the baby has bled a lot while clamping. Attention was given elsewhere, the cord was cut, the baby had, we'll never know that. And the baby is born with a low hemoglobin because of bleeding, which is not obvious at all. And you find there is no obvious cause. It may be a physiological, but out of proportionately more for physiological, because the baby was born with a low hemoglobin due to hemorrhage, which was, so to say, occurred. Not exactly occurred, but not known.
Okay. So can it be bone marrow problems? You said aplastic anemia. So which aplastic anemia is seen in infants? Any thoughts? Bone marrow problems?
diamond blackfin is one that can present.
So pure red cell aplasia or diamond black. Maybe it comes a little later, but 2 months, maybe not, right? Okay. Then can it be a leukemia?
Too early.
Oh, it can be infantile leukemia, congenital leukemia. But for clinically, what is the point? Very good. So thrombocytes have a shorter half-life, and therefore manifestations of thrombocytopenia would be equally there along with the pallor, right? So that's not at least complained of on examination. You could see that's at 2 months. Now baby is 17 months, right? So this is the way you'll think at 2 months. What are the different categories and go through all that. Now you know this baby has been multiply transfused. So now what do you think? So what do you think? After receiving so many transfusions, which of these categories this baby fits into? Do you think it is a pure red cell aplasia?
No.
Why
Because
not?
other cell lines are not involved. Other cell lines are not involved.
Yeah, so other cell lines is not affected in pure red cell. That's not a complete aplastic anemia. It's just a red cell problem, right? There's no bone marrow aplasia. So that is possible that other cell lines are not affected. But what is still against that bone marrow problem? You're getting what I'm saying? When you have a history of these many transfusions, based on that, how can you say this is not just a lack of production? Very good. Frequency of transfusion. So how do you come to that? Excellent. Lifespan of RBCs, no, 120 days. So if it is just a lack of production, you wouldn't need it every 15, 20 days or whatever you have said, right? So there has to be active destruction, right? So that tells you that this is a hemolytic anemia. Okay? Come.
Mm.
Then why there is no icterus? Okay, which hemolytic anemia will give rise to icterus? Pardon? Sickle cell anemia, erythrospherocytosis. They will not. It will also depend upon the constancy of hemolysis, the degree of hemolysis, whether the hemolysis is occurring very slowly, so that the the product of hemoglobin degeneration, hemoglobin are compensated very well by the liver, and therefore the bilirubin may not appear clinically. Okay. And if there is something occurring at the level of the production itself, that the production is not really right, and therefore there is ineffective hemopoiesis and destruction taking place at bone marrow level only, then also you will not get jaundice there, icterus there.
Coming to the summaries.
We will find that out soon.
So in thalassemia, the problem is that the uh, the cells are destroyed in the bone marrow itself because of the imbalance of the hemoglobin, right? So it is known as ineffective erythropoiesis. So that is why that is not coming in circulation, so you don't get icterus. If a proper RBC was destroyed in the spleen, then you would get to that cycle of hemoglobin breaking into heme and globin and then bilirubin and all that cycle will happen, right? So that is not happening because it destroyed much before that.
Hereditary spherocytosis, because of the problems of the membrane, it is actually destroyed in the spleen, and therefore there is mild icterus in that.
17-month-old male child presented with case of increasing paleness of the body since 2 months of age, with multiple history of blood transfusion in the past, which in a developmentally normal child, partially immunized, born out of third-degree consanguineous marriage, is probably a case of severe anemia under evaluation, likely to be hemolytic in etiology. Child is lying comfortably on a mother's lap. Coming to head to examination, head to toe examination. Uh, the bill. Mm.
उठेगा तो रोएगा कि चलेगा?
Head appears normal, the face appears normal, sorry. Or there is no dysmorphic features. Child appears normal build, thin build, thin build. The trunk and upper limb and lower limb appears normal. There is no edema of the feet. There is no aqueous equivalent.
Is he pale?
Thus, the complexion is not.
He's pale, he's moderately pale, he's not pale. He's pale, he's moderately pale, he's not pale.
Baby is quite irritable, so it's okay. We'll skip that, right? You've examined earlier, no? So you tell us the findings. Come.
एक मिनट बहन जी. Right.
Coming to the general examination, the child is febrile, heart rate of 150 on presentation, respiratory rate of 36, SpO2 of 99 on room air, peripheral pulses were bounding, extremities were warm, failure was present.
Okay, so now why heart rate is 150?
There is tachycardia because of anemia.
Very good. And why bounding pulses?
Because of high volume pulse,
Because of
because of the volume, increased volume.
hyperdynamic
Hyperdynamic
circulation because of severe anemia. Okay, fine.
Head to toe examination, head appears normal, no dysmorphic features. Chest and abdomen appears normal, back and spine appears normal, extremities normal. Coming to the systemic examination, on per abdo examination, inspection, abdominal distension was seen, length normal, all quadrants moves with respiration, umbilicus was inverted, skin is normal, no scars or sinuses seen, hernial orifices were free, external genitalia is normal, palpation inspectory findings are confirmed, superficial palpation, no local tenderness or rising temperature. On the palpation, liver is palpable 6 cm below the right subcostal margin in mid-clavicular line, firm inconsistency, rounded margin, non-tender, border well felt and regular. Spleen is palpable 5 cm below the left subcostal margin towards the umbilicus, firm inconsistency, smooth, non-tender. Percussion, liver span of 10 cm, resonant not heard over the abdomen. Auscultation, bowel sounds is heard. Coming to the investigation.
No, so you got hepatosplenomegaly and you've got severe pallor, right?
Yes, sir.
So now you have to give some differential diagnosis. No, so what can it be? You now put everything, history and examination together. Sorry, you were telling us the anthropometry earlier. Tell us that.
Weight of 9.1 kg, falling in -3 to -1. Height of 78 centimeter, -2 to -1. Head circumference of 45.5 centimeter, falling in -3 to -1. With upper arm circumference of 13 centimeter, -2 to -1. Weight for height is falling in -2 to -1. So impression is complete.
So how come the growth parameters are normal if it's a hemolytic anemia? Normally, hemolytic anemia should have growth failure or they should not have.
It should have.
So here, how are they normal?
Maybe because we are giving transfusions every 15, 20 days.
If it is well transfused, then maybe that is maintaining the growth. But check your readings again, right?
Yes,
Okay, fine. So now what, before you come to investigations, how will you add everything and tell us? So you have to add your history of multiple transfusions presented at 2 months of age. On examination, you have hepatosplenomegaly. So now put everything together and give some diagnosis.
17-month-old male child presented with complaints of increasing paleness of the body with in a developmentally normal child with normal anthropomet. Partially immunized with on systemic examination hepatosplenomegaly is found. With that, can be a case of severe anemia under evaluation likely to be likely.
Yeah, so now that you have got hepatosplenomegaly, of the 4 categories that we talked of, we said deficiency, hemorrhage, bone marrow, and hemolytic. In which of these you can get liver spleen? Hemolytic and which type of bone marrow? The leukemia type of bone marrow, not the aplasia type of bone marrow, right? So now why is this not leukemia after examination?
In leukemia, we can find other cell lines involved.
Very good. So you did not find any petechiae, etc. So this is not the leukemia type of bone marrow involvement. So therefore, this is hemolytic for sure. Now you have to say which hemolytic. So which hemolytic can it be?
That based on the age group, alpha thalassemia is one possible. Or
Pallor hepatosplenomegaly, he said, is apart from hemolytic, could be a bone marrow problem, usually leukemia. There is one pallor hepatosplenomegaly, which is not leukemia. Bone marrow problem. Little biggish hair. When you saw the X-ray, you said, oh. Heard of osteopetrosis, marble bone disease, bone marrow problem, not leukemia. Pallor, not be significant pallor like that. Just keep that in mind.
This is the trend of the CBCs that was done outside in private hospital. We can see here that the HP at this HP is 4.5. After transfusion, it was 6.9. Following that, also the hemoglobin levels were between 4 to 3 mg.
Yeah.
if he's maintaining between 3.5 to 4.5, then he should have growth failure.
Yeah, he should have. So one is, what are your thoughts on that? Why is he not failing? And the second question is, why is this hemoglobin not going up in spite of transfusion?
So maybe it's not feeling because there is compensation with the heart, like we saw increased heart rate, and then there is hyperdynamic circulation also. So maybe it is being compensated.
Your thoughts are right, but usually that's not good enough, right? So one thing that I noticed is that the father was tall, right? So we are saying 78 centimeters, right? This child, or 17 months. So, I mean, it's okay. 78 is a normal height of around a 15-month-old, 14-month-old. And here the father is tall. So whether this child was destined to be 80, 82, and whether there is already some failure that we don't know, that part is.
This child will show his growth failure, not now. He's 18 months. If you see him at 6, 7, 8 years progressively, he will show growth failure. Okay, it's not that so acute and in the early part of life, so as to get a reflection at 15 months. But I'm sure if you see him at 6, 7, 8 years, he will show.
What are your thoughts on that hemoglobin not rising in spite of blood transfusion?
Inadequate volume of transfusion. That's it.
Inadequate volume is one, so you have to ask. So what is the history? Is it inadequate or you don't know the volume? Outside this baby was transfused, no?
Yes, sir.
So what was it? Was it inadequate or what?
And the quantity is not known.
We
The
don't know
mother-
the quantity. Okay.
What we have given, are we given Paxil or full blood?
No, actually, the mother does not know whether.
Right. The mother does not know. Ideally, we should give what? Packed cell or whole blood? Packed cell. For anemia, always packed cell, right? Whole blood is now very, very rare indications. Okay. So,
Very old, September reports are there. What are the recent reports?
any other reasons for lack of rise of hemoglobin besides inadequate, which you said?
There is also splenomegaly, so maybe hemolysis of the blood that you are giving also.
So splenomegaly is anyway a part of the disease process, but you can have a autoimmune component to the hemolysis, and that could aggravate the problem, right?
Yes, recent transfusion.
Quantity and the good rise is showing after transfusion.
Okay. One.
This is the lipid profile and liver function test and the renal function test, which is found to be normal. Outside test was done for the father and the mother. HPLC testing was done, for which the father and the mother was found to be thalassemia trait, and the baby is found to be homozygous.
Beta thalassemia.
Beta thalassemia.
Okay. Okay, so now why have you given sickle cell as a DD? Just tell us any reason why you've given sickle cell. No, you're not sure. Okay. So does sickle cell anemia need so many transfusions? They don't need so many transfusions, right? Okay. So it has to be some kind of thalassemia, and it's turned out to be beta thalassemia 0. It's mostly like going to be 0, right? So almost no beta chain production. That's why it has manifested very early. Okay. Yeah, very early presentation, right, Palni? Any other questions you all have? Sorry?
But how did we rule out sickle cell anemia?
So one is clinically it doesn't fit in. Clinically, sickle cell anemia at this age would present differently. In an infant, it would present with what is known as hand-foot syndrome, where they get dactylitis and painful hands and feet. Okay. Or they may come with a sequestration crisis like a big spleen, some such presentations. It doesn't require frequent transfusions. And finally, of course, the hemoglobin electrophoresis has been done and that did not show sickle.
Fetal hemoglobin protects for 6 months.
So Joshi sir is saying that normally B1 beta thal presents a little later because in the first few months there's fetal hemoglobin which doesn't allow it to manifest, and then as fetal goes down and HbA has to come up and it doesn't come up, that's when it starts manifesting. But it all depends on how much is the production of beta chains. So if it is close to 0, then it may present very early, right? Okay, why MCV was not low? Any thoughts? So should MCV have been low? Why?
Yeah, yeah, the ones which have been transfused from a normal individual.
So, uh, uh, one answer given here is that because he's frequently transfused, you are not really getting the original picture of microcytic hypochromic. Anything else?
Could it be any other reason? This child is young now. Could it be additional deficiency of some kind, which has B12? So whether the B12 deficiency is making some changes in.
So we don't have that, Palni, any smear study done before the this thing we don't have.
Could it be also like as we can see, he was transfused every now and then, which means that the need of the blood in the body was a lot. That's why the bone marrow or the body released immature RBCs, which led to increased MCV.
Yeah, so theoretically what you are saying is right, but the size of the cell also depends on the hemoglobin. So when they are low on hemoglobin, they are going to be low on MCV and MCH both. So you are right that the premature RBCs are little bigger in size, but here you are going to get a collective, MCV is a collective impression of all the cells. So old cells, new cells, transfused cells, immature cells. So it's a averaging out of everything, right? So that's why probably it's normal. Okay, any other questions from the online audience or any comments? You can unmute and talk.
थैंक यू वेरी मच अम्डेकर सर। आप जियो हजारों साल, साल के दिन हो 50,000। We are very grateful to you for this online webinar, and we thank all the faculty for taking the trouble for bringing this online.
Thank you. Thank you, Anjali.
And thank you to all the students who presented it today.
Thank you. Sir, you were saying.
The carrier rate for this illness in Greece, Cyprus, Mediterranean region is 25%. Still, they make no babies with major illness. The carrier rate is here is very low, but we make thousands of babies because we fail to educate people. So after you grow up, let's do it. Any prenatal diagnosis? Possible. What? I mean, just few days back, I saw a thal major. Parents knew that they were thal minor before marriage. They got married. They got the babies thoroughly right from the embryonic cells, etc. Everything was thoroughly tested, reported to be normal, yet the baby is thal minor. So there are limitations. Whatever analysis they must have done, or the fetal blood, and they must have drawn the blood, and what studies they did on the zygote, etc. I don't know, but there were still limitations. In spite of being warned, forewarned, they accepted the whole thing, yet the baby is terminated. So what is the answer to them now? Obviously, they'll go for marrow transfusion, I mean bone marrow replacement. So they are gone for bone marrow replacement, but they were told that just wait for some time because the gene therapy is coming in a big way now. And if the gene therapy comes, maybe you will be able to avoid the bone marrow replacement. So they are waiting for better results with gene therapy. Okay.
Just hold on. We'll just celebrate Sir's birthday. Online viewers, just wait for 5 minutes.
Yeah, if you have 18 December on the Thursday. Come. Okay. No, don't do that. Don't do that. Thank you. All right. So remove the guillotine.